ACEP Frontline, and today is a special episode that we've put together to chat about the recently released, actually almost exactly a month ago, ACGME proposed changes to EM program requirements. And there's been a lot of chatter about this. It's got some legs, and it's run quite a distance. And so I wanted to get the people in the know, the ACGME, to talk about it right here on the podcast, so we can let them tell their part of the story. For many of those, there is an open comment period, open now through May 1st of 2025. And there was the ACGME webinar that took place. That recording is available as well from ACGME, as well as through the ACEP website, if you want to check that out. But this is really more about the conversation, and I'm joined by Dr. Linda Reagan, Dr. Doug McGee, and Dr. Tiffany Murano. And, we're appreciate them being flexible. It seemed like they had a meeting, like as soon as this was over, it's like, good luck, here comes all of the deluge of feedback, and let's go to a meeting. So kind of give us, first and foremost, we'll start, Linda, with you, Linda, then Doug, and Tiffany, because that's where you are across my screen. Give us a little bit of information on yourself. Give us a little background.
Sure. I am currently in Baltimore at Johns Hopkins. I'm the Vice Chair of Education for our department. And in my role here at the ACGME, which is why you're talking to me, I'm the chair of the review committee in emergency medicine and the co-chair of the writing group, which is the group that is writing the proposed program requirements.
And I'm Doug McGee. I've been in graduate medical education for more than 30 years and have had just about every job in GME that you can have. At the moment, I'm Vice Dean for graduate medical education at Thomas Jefferson University, and I am Enterprise GME lead for all of Jefferson Health, which is a big GME system. I am the immediate past chair of the review committee and also co-chair of the writing group.
And I'm Tiffany Murano. I am Vice Chair of Education for Department of Emergency Medicine at Columbia University. I also have a role as an Associate DIO with New York Presbyterian Hospital. And I am the Vice Chair of the Review Committee, also Chair-elect of the Review Committee, and I'm a member of the writing group.
All right, so the thing that boils down, there's a lot of information that was here. But I think the big thing is the recommendation right now. Emergency medicine is composed of 3-year and 4-year programs. Recommendation here is the 48-month program. For those that have the historical mind to remember that emergency medicine wasn't always a 3-year residency either. And those that were around back when the 2-year to 3-year transition happened, remember kind of the similar type feedback at that point as the specialty has advanced in terms of complexity. It looks like it was like until 1985, you had a PGY 2 and 3 format permitted at that point. So we're really talking about almost 40 years ago that we had that initial transition, and they became obsolete looking at some of the data finally in about 2011 to 2012 with pretty decent amount of formats that have happened in between. So, whatever order you guys want to go in, kind of what I would like to get is just some feedback from each of you. I don't know, Doug, did this start under your leadership side of the committee?
Well, that's a really good question. If the question is, did this start? If the did this start is a discussion about what the right format is for emergency medicine, this discussion has been going on in emergency medicine for quite some time. And I think, as you correctly pointed out, over the years, we've had lots of different formats. And that in many ways is probably reflective of the notion that emergency medicine as a discipline in the House of Medicine really isn't that old. And so, I think that some of the evolutionary changes we've seen have been a consequence of what is the changing landscape of emergency medicine and what emergency medicine has become. The road that we've traveled here is long and interesting. And I trained long enough ago that I can remember where we had to fight anesthesia for succinylcholine because we didn't do rapid sequence intubation, and procedural sedation was something that was also a hard-fought battle. And we've had a lot of those over the years, and it's been difficult in emergency medicine to get the respect we need and head our own specialty in the direction that we wanted to. But I think what's really important about where we are now is that road, while it's important, was not really the basic notion behind why it is that this project was engaged by the review committee. And the review committee the ACGME rather asks every review committee every 10 years to take a look at its program requirements and not fix what's broken and not make them better, but to stop for a minute and ask, where are we headed here? And the process here, I think, was really fascinating. It was a strategic planning process that was future state planning. And we've given some of these details on some of our other presentations, but basically we were asked, what does an emergency physician need that we're going to turn out into practice, tomorrow? And what do they need for the next 30 years? What does that look like? And we spent a lot of time in lots of different groups trying to envision what that might look like. And from that then came a whole new definition of what an emergency physician is. And I think that that's a really important starting point for all of us. That turned into, well, what is it that the emergency physician we've just defined needs for competencies? And we wrote the competencies, and then from there became the program requirement. So this was really a forward-looking process. It wasn't aimed at fixing anything that was broken. It wasn't aimed at comparing 3-year programs and 4-year programs, and it really doesn't address the notion that some of the comparisons that have been made in the past for 3-year or 4-year programs, because what it is that we've proposed is wholly different than what it is that we have now. So it's been a very forward-looking process, one that we think will put the specialty on the right track for, literally the next generation of emergency physicians to come.
Well, it really wasn't that long ago for the intubation aspect of it. 17, almost 17 years ago, when I became an attending physician at my small community hospital, they did not allow anybody but anesthesia to do any type of RSI. So we're up there trying to flog patients on the floor to intubate them with Versed and morphine. It wasn't until we demanded that the anesthesiologists come in 24/7, 365 within 10 minutes,
right,
that they willingly gave that up for a wonderful night's sleep. So it's typically a little push to understand what happens. And even when I started off as a surgery intern back in 2003, emergency physicians didn't do a lot of the trauma either, especially at level 1 trauma centers. It was completely separated. So, there has been significant advances in terms of our skill sets, breadth of knowledge, skill. Not just skills, but procedures, looking at ultrasound, some of those things and more, that's what's being pushed on the emergency department to manage. And so, Linda, now as the chair, talk about, some of the experiences you've had kind of working through this leading up to this February announcement.
Well, it's definitely been a lengthy process. I will say that this is probably we're coming up on 3 years. And this is actually the end of my 3rd year as chair. So it coincided right with me taking over as chair that we were engaging in the process that Doug talked about. For me, I'll say that it's been both a stressful, exciting, very important experience, because I definitely feel like we have really thought very hard and intentional about where we are going to be as a specialty. And I think Doug said this the other day when we were talking with some of the resident organizations, like, we're at this sort of inflection point, this perhaps transformational point, where we are going to really change where our specialty, how we look. And for me, it's been a very rewarding process as much as it's been a stressful process, because we don't live in a cave or anything. Like, we are very aware that we are proposing very significant requirements that are going to that were going to create a lot of emotion as they did, and that are going to, if they go into effect, create challenges for people to be able to work through. I think that for me, my hope is that emergency medicine, as I believe it always has, will embrace change and use their adaptability, which is what makes us unique and special, to be able to answer how we move forward. What's the best way to transition if in fact we're going to? What is it that we need on our path? But personally, it's been extraordinarily rewarding, and I say I feel like I've talked to Tiffany and Doug and Felicia and Nikhil more than my family sometimes. We spent a lot of time, and you know, for me, it's really important that the community realizes that this is a multi-year process with extensive research and multiple stakeholder conversations, and really thinking about who the emergency medicine of 2040 or 2050 is going to be. So I'm really proud of the time and the work, and excited to see Tiffany take over in the next year.
Yeah, he probably did tell you as soon as it was coming on. It's like, congratulations, by the way, you're going to have this entire course. It's like the president of ACEP that inherited COVID. It's like, I know you had great ideas, but here you go. So Tiffany, as you're coming into this, you know, and ACEP is broken down 6 major changes. Everybody, of course, got really hung up on the 48 months or the 4-year program recommendations. But that's not the only things that are changing. You know, recommendations are some of the curriculum building blocks, some of the resource requirements, exposures, procedure requirements, scholarly requirements, and didactics. Dive into some of those things that have been recommended in terms of the changes we could see in emergency medicine matriculation coming up.
Yeah, sure. Well, we're certainly excited about many of the changes. Well, really all of the changes that we're proposing, and are cognizant of the fact that perhaps there were things that we didn't think of, right? So that's why we're really eager to get this feedback from the emergency medicine community, because, you know, we took in a lot of perspectives, a lot of information into creating these proposed requirements. One of the new changes is procedures. We parsed out some of the pediatric procedures. We more clearly defined the resident's role as leader of resuscitations. We added some procedures such as arterial lines. With respect to faculty, we try to really empower programs by requiring that there be certain faculty with areas of experience, so that they can create curricula, implement the curricula, and then be able to impart that knowledge and assess their learners. And ultrasound is one of them, simulation, medical education, etc. Uh, we are now requiring some rotations, so administration, based on stakeholder feedback. So administration, toxicology, for instance, EMS. And realizing that there are many programs that are already doing that, but we thought, based on stakeholder feedback, that these elements were really essential in creating this new curriculum. Um, uh, we also heard from our stakeholders that there was a perception that recent graduates perhaps weren't as comfortable doing some of the bread and butter type procedures that are seen in the lower acuity areas in the emergency department, like lacerations, INDs of abscesses and paronychias and so forth. So we are proposing required time in low acuity settings. We also heard from our stakeholders that the trainees would highly benefit from a wide variety of practice environments. So the low resource and high resource environments were also proposed requirements. I'm sure I'm forgetting some. There were many, but I think that those are some of the major elements that we considered.
And for us, you know, on the emergency, on the ACEP side, of course, with the work study that came out a few years ago, you know, is always the discussion of, you know, maybe it feels like we've got too many emergency physicians in certain communities, but we still have that challenge with distribution. And so there was that addition of lower acuity settings and lower resource emergency departments, as well as some of that focus on more of the rural community critical access systems. So, you know, staying with you, Tiffany, is, you know, with that in mind, is the hope not only to give them exposure outside of that large academic center where most of us trained and got all of our exposures, but then we end up in community settings. Like I'm in a community setting now, started off in an urban community hospital, have worked rural hospitals, to get them more ready, potentially exposed, and maybe even interested in those work environments for a career.
Yeah, that's a great question, Ryan. And we were when we were sitting around sort of talking about experiences that residents should have, it brought us back to that medical student experience, right? How do students know that they want emergency medicine if they don't do rotations in emergency medicine? And that was really the impetus for that big push in emergency medicine, for having EM as a required core clerkship in medical school, right? And I think it's very similar to these low resource settings. How do you know that this isn't something that is you're really passionate about if you're never exposed to it? I think that that's a great point. And Linda and I recently met with a faculty member who's am I allowed to say she's an ACGME site visitor, she exclusively works in a rural setting, and she said if she didn't have that exposure, she doesn't know that she would have ever worked there. So I think that this is a great opportunity for our trainees to see this practice setting and really utilize their skills, learn what it's like, and see if it's the right place for them to spend their career, or even a portion of their career.
Ryan, can I just add a little bit to that? Because I think it's we have a lot of jobs as program directors, and every one of us have been program directors. And part of the job is to get the patients safely cared for, get the residents ready to take care of patients, and that's a really important part of it. But the other important part of it is that we have to get the residents ready to work in the job where they're going to work. And the practice environments in emergency medicine are so varied that training a resident who's not really sure where they're going to work or where they're going to end up can be a challenge. And I think we heard that from our stakeholders, that we hire your graduates. And when we hire your graduates, we assume that they're going to take good care of patients, but we have to be sure that they can work in the environment that we put them in. And when I was program director and someone would call and ask for a reference for one of the residents, they almost never asked, can this person take care of patients? They ask, can this person work in a department where there may not be a consultant that you can have come down, where there's not a lot of resources. We might have to send patients out. And so it's our responsibility, the review committee and the ACGME, to make sure that what we're doing is getting the residents ready to function in the workforce. And that could be literally anywhere. One of the side benefits of this whole thing is exactly what Tiffany said, is maybe somebody will be interested then because they've got some exposure they wouldn't have otherwise. But I think it's important to note too that in any big city, literally, a mile from my hospital, which is in urban Philadelphia, there are low resourced hospitals just, literally in every city. So I think it'll be a good thing for the residents. It will help us satisfy what it is that one of our other responsibilities is, and that's to get people ready to work.
And I was going to save you, Doug, for a couple of the myth busting here in a few minutes. Some of the feedback things we've gotten. If folks look back at the evolution of emergency medicine and the expansion, just looking at the subspecialties, of which now I believe we have 13, something like that. Looking at the 1990s with PIM and sports medicine and tox, and then in the early 2000s, the hyperbarics and the palliative care, and in the 2010s, which would have been about the time of your last recommendation review, which, as mentioned earlier, was Q10. With since then the critical care, EMS, one of the internal medicine critical cares, pain management, and then looking at some of the POCUS type things as well. So emergency medicine has grown significantly. Even since I was a resident, I consider myself kind of in that mid-career range. And even now tonight at my shift, the hospitalist was surprised that we do the ultrasound guided arthrocentesis down here in the emergency department, because he thought he was going to have to consult in orthopedics to do it. And so went ahead and knocked it out. So that stuff's running for them. And so there's a lot of things that are expanding. So Linda, kind of talk about the 48 months and how that landed, because I've heard both ways, that some feel like they need 3, some feel like that programs feel like they need 4. The landing on the 4 years, looking at this plethora of kind of expanded emergency medicine. Interestingly, people are shocked at recommending more than 3 years when actually we're probably the requirement for the most expansive knowledge base in all of healthcare, considering we are the home for the acute phase of care and the place where most people land now, even if they do have primary care. So kind of give that an idea of when you've got your little matrix out there and looking at everything in the abacus and the calendar and looking at it on the 48 months.
Yeah, definitely the abacus was heavily used. So, I think we've talked about this, I think, pretty extensively in the webinar and at our updates and such. But the answer is really that we sat down and said, how much time should you spend in this specific area? How much time should you spend in, pediatrics? How much time do we think you need in critical care? And we very much approached this without thinking about what the container or the bucket outside was in terms of length. We really only focused on how much time we thought ideally you would need to train to be the effective new emergency medicine physician of the future that Doug mentioned we had a definition for. And when we added all that up together, it was clear that 36 months was not going to support that degree of training that we were hoping would be proposed. I'll take a second and also talk about the survey, the PD survey that I know has gotten a lot of comments. And if you're not a PD and you weren't at a conference, you may not have no idea what I'm talking about. So in order to sort of take a different lens from our group, we actually sent out a survey to all the program directors of the primary EM programs in the country and asked them to build a curriculum of how much time they felt an individual would need to train in order to be able to be independent at the end and successful in practice. We told them in the introduction in the email that this was to help inform the program requirements that we were in the middle of changing. And we told them very specifically that you can't go back. So once you've decided that you now say you have 6 months of pediatrics, blocks your pediatrics, you can't go back and change what you said before. And we looked at their total, and their total was longer than 36 months too. I think the survey has come under a little bit of criticism for a couple of reasons. In particular, the fact that we didn't let people go backwards. And how did we decide to do that? It was very intentional. The ACGME actually has a survey expert methodologist that we worked with, and there's prior literature that shows that if you ask people how much time you should train, it's very dependent on where they trained. If you trained in a 3-year program, you're going to say 36 months. If you trained in a 4-year program, you're going to say 48 months. But if you have them build it without knowing what the denominator is, the average of programs, regardless of whether or not you're from a 3-year or a 4-year program, they're all longer than the 3-year program. And so that's how we ended up at 4 years. They wouldn't let us do 3.5 years. And in fact, once we added vacation, which probably is an important thing for each year of our trainees, we were past that amount anyway. So really, we looked at the building blocks and not the bucket until the bucket was revealed at the end to be longer than a 3-year program could support.
All right, here we go. Because this is, where'd it go? I had it pulled up here for what we were doing. An AI generated review of what was online, Reddit, ACGME, FAQs, all that stuff, on some of the myths and feedback. And so, Doug, I'm going to start with you, but I want all of you to jump in as you feel, because we're just going to do a little bit of myth busting here, because that's my favorite thing, is to kind of answer the questions that people are inevitably thinking as they listen to the podcast. First one is one that I've heard both ways, and so we're going to address it both ways. One is that the idea of the 4-year was potentially a money grab by hospitals in order to promote cheap labor in the department, whereas the flip side of that as well was also a discussion and argument that it will significantly increase the cost and burden upon hospitals trying to support a 4th-year resident. Kind of address that thought. Go for it.
Well, that's a good question, and I think that that's an important question because GME costs money. I'm I'm responsible for a lot of GME programs in our system, and we pay attention to our programs and how much they cost. And for the most part, there's a lot of GME money that's sent from the federal government to support GME, but most of us are over cap. So a program has to think carefully about starting a new program, expanding a new program. And I think that programs that are in the 36-month format are going to have to sort of make that same consideration. So it's naive to suggest that there's no financial implications in either direction. This may be financially beneficial. This may be more costly, but it in part depends on how a program decides to transition from a 36-month to a 48-month program, whether that's to make your class size smaller with the same or similar complement, or whether it's to add another class. And ACGME doesn't really consider what it would cost necessarily when it comes time to make program recommendations. It's a really important consideration. I think it would be naive to say that it's not. But the most important question we were trying to answer is how long, how many, what do, and in what form do people need to train to become safe to take care of patients and enter autonomous practice? And that's really what the goal was. So during this whole process, we didn't look at what it would cost. We didn't look at what revenue it could generate, what expense it would be. We spent time looking at how long the program should be for pediatrics and for toxicology and for critical care and emergency medicine. That's what informed the length of training. And I think we're going to have to see how programs move forward. And I know the CORD, which is super supportive of the emergency medicine GME community, will help develop modules and curricular tools and financial assessment tools to help programs make that transition. So I don't know. And I think that the answer is different probably for every place. What does it mean financially to your place? Depends on literally your place. But what it means for everybody is we're going to have a curriculum that's important for us going forward. And that's really what we tried to look at. We didn't really look at the money, honestly. That's not to say we didn't care. We don't understand. We didn't for a second believe that programs would just do this without thinking twice about the finances. But our goal was to make the program fit for our patients.
Yeah, I mean, I would 100% agree. We don't live in caves. We've seen comments too, and I will say, the theories that are out there that there were bribes and money tied to our decisions is completely incorrect. And I just want to reinforce that, what Doug said. We created the curriculum that would train our future emergency medicine physicians the best to care for our patients.
All right, so a couple more popped up. It was awesome. Another concern, for those is the potential financial impact on the residents. Is they put back one more year with the cost and potential loan with that. Was, as you guys mentioned, I'm glad to hear there wasn't really the financial positive negative impact weighing on too much in terms of the hospital's residencies. Is more that quality and to getting the appropriate exposures and education that they need. But with that in mind, how do we address or how do we message to residents who are coming up expecting a 3-year program and now pushing that 1 year further back in terms of that first initial paycheck? And do we believe kind of the theme of that is that it potentially could deter folks going into emergency medicine, considering kind of the uneven ground that we had over the last few years with regard to the match? Linda, you get that one.
Thanks. I mean, I'll say, we've definitely spent a fair amount of time talking about the impact this may have on students, and especially with over the past, 4 or 5 years with the ups and downs that emergency medicine has seen in the match. I think that for the committee, this came down to the fact that, one, like Doug said, we were looking to see what you need in 15 years to be effective. And, what will we say to the students who will be pushed back a year? Well, we're providing you with the training that will enable you to have longevity in your career, and take great care of your patients. That's number one. I'd say the second thing is that, if you take emergency medicine out of the mix, there are only 3 specialties left that are 3 years: internal medicine, family medicine, and pediatrics. They're all essentially primary care specialties. Emergency medicine is not a primary care specialty. We're a specialist specialty. And we prepare residents to work in every location to see any type of patient at any time. And as many of our students consider, do I want to do anesthesia or do I want to do emergency medicine? A lot of the competing choices many of our medical students currently make are 2 programs that are not the primary care specialties. They are 2 programs that are 4 years, or surgery 5 years. And so I think that, if the difference between choosing to go into emergency medicine, versus choosing to go into anesthesia, let's say, is that you don't want to do an extra year of training, then maybe your passion for emergency medicine isn't what you thought it was, right? If the difference between a year is going to make you choose a different specialty, when in fact the majority of specialties that are not primary care are all 4 years or greater, I think that it feels like it's a very big deal right now, and it is. We're not saying money's not a big deal, but in the big picture of how emergency medicine is preparing graduates in the house of medicine, we're not in the small number when we think that we need more than 36 months to do that. So I would start there and see whatever else Doug and Tiffany have to add.
Yeah, I think I would add, and you tell me if I'm incorrect, Ryan, because what I was hearing was that maybe there's a perception that if these program requirements go into effect while a trainee is in a 3-year program, they'll be required to do an extra year, and that is not the case. The earliest that the program requirements would go into effect would be 2027. And so any residents who match into 3-year programs before a program converts into the 4-year format, they would complete that training format in which they matched in. So it wouldn't be like a bait and switch. So I just want to be clear about that.
Yeah, I think Linda hit the nail on the head here. You want people in emergency medicine that love emergency medicine, that want to take really great care of patients and want to do that for the rest of their career. And that's not for a second to say that the 3-year training format as it exists now, or the 48-month training format as it exists now, doesn't do that for people. But we're looking forward here. We want to try to have a curriculum that works for a very long time. And I think that this piece of this is going to matter to medical students as they start to think about what it is they want to do. I would hate for a second to say, well, let's just make emergency medicine 2 years then, so people will join our specialty and get out and start earning. That wouldn't make any sense. The goal here, with this particular question you're asking, is very similar to the financial question about the hospitals. It's sort of, I don't know how to say it so it doesn't sound like it doesn't matter, but it kind of doesn't matter. Our goal is to make sure we take good, safe care of patients. That's the job of the program director. That's the goal of the resident when they're in the program. And it should take as long as it takes. One day, maybe we'll be to competency-based medicine and we'll have, a different sort of view in this in a different format. But this process is aimed at making sure that the resident has the tools to safely enter autonomous practice. And if that's what it takes, and somebody doesn't want to do that, that's really fine. It's really okay. People now select anesthesia, as Linda pointed out, much longer. People take surgical residencies, which are much longer. And now, for literally decades, people have selected a 4-year emergency medicine training format. So clearly, it's not the end of the world, but people that choose 4 years now have their reasons for it. And I think it's okay. This will be one of the other facets to the discussion, but Tiffany made the point that we're not going to involve anybody that's in a training program now. The people that could be impacted on this the earliest are literally second-year medical students right now, and they have not done a single clerkship yet. They've got a lot to look at and a lot to think about, including how long the training program is and how it's formatted and where it is and what's in the specialty. This specialty does not look anything like the specialty that I joined when when I finished residency in 1991. It's different. It just evolves, and that's going to continue for the next decade, next decades. That's why we did what we did here, the process we engaged in. So the medical students will figure this out. They're smart, and those that are in the pipeline now will finish the format they started, and I think it'll be okay. The medical student debt is another whole topic altogether, you know.
And I've got two more of the myth, and then we'll let you have your closing thoughts and messaging of whatever it may be. We have the ACEP workforce study, which, I think everybody at this point feels that the workforce study was wildly underestimated the annual attrition of physicians in terms of full-time practice in emergency medicine, not to mention the attrition of just the environment right now, including me. I'm one of those people that started off with 16, 18 shifts a month and is down to 8 to 10 with other jobs. But, looking at that aspect of things, was that consideration, part of the feedback was that this was an attempt to potentially cull some of that growth or limit some of that growth in residency programs, in which we went from 1,399 positions in 2008 up to about 3,010 back in 2023. Was there any, a lot of people say that growth is putting that, a huge amount of blame on that growth on private equity-based residency programs, some of the HCA-based programs, looking for that, trying to drive down the value of the workforce. Was this in any way, shape, form, or fashion an attempt to potentially guardrail or cull some of these residency programs that currently exist or we're thinking about existing?
So I think that's my question.
Yeah.
Okay.
Well,
Oh,
go
is that
ahead.
mine?
We're all going to be like, no.
Go ahead, Jeff.
No.
Go ahead, Tiffany.
Yeah, the ACGME is an accrediting body. It's not in the workforce is not in the ACGME's lane, and it was not even a consideration, not a thought in our mind when we were creating these program requirements. We made the requirements irrespective of what the workforce predictions were. Our requirements and our building a 48-month curriculum was not an attempt to close small programs or close any of the contract management group sponsored programs. We're here to support programs. We're here to accredit programs. We're here to create curricula that is going to be safe for our patients. So the one word answer is no.
Yeah, the ACGME's charge is pretty straightforward here. Here are the requirements. Do you meet the requirements? And if you meet the requirements, then your program will be accredited. We think that the proposed program requirements can be met by the programs that we have now. And I think that there's going to be some work and some curricular adjustments that are going to need to happen in all of our programs, both the 36 and the 48-month programs. But I'm confident that emergency medicine will solve this problem like every other problem we've solved in our fairly short history. And I know that CORD will do all it can as a community of supportive program directors to try to help each other do that. And at the end of that, we'll end up with better training programs, better 48-month programs, better and a better training paradigm for the residents altogether. So yeah, the answer is no. And I think it's okay. We have grown GME in the United States here, and we do it for lots of different reasons. But those reasons were not really part of our discussion here at all.
To make note, Linda didn't do the long response, but she did respond no during that initial aspect of it. So it's 3 for 3 on that one.
Did you hear all of them, Ryan? I think we all said no at the same time.
Yeah, I got all three.
I could say the same thing, but I don't need to do that because Doug and Tiffany were very eloquent.
Appreciate it. Because that's actually the one thing I get this feedback I got pulled up is the main thing is the idea behind restricting and culling programs, which I can actually see it from both directions on, opportunities for programs as well as, honestly, if a program can't meet the recommendations and qualifications, do they need to be a residency to begin with? And we're seeing that this year with a few programs that have that are not going to be programs moving forward, and that's well before any of this has taken place. Final question, because this is one that we get quite a bit, and a lot of people have this, the whole South Park, they're taking our jobs idea with returns, with ideas of PAs and NPs, which still don't require any formal education within emergency medicine to work in an emergency medicine, or honestly anywhere for that matter. And with the limited amount, is there any concern that increasing the requirements among emergency physicians could further, with that in that that expertise and that specialization could further drive some of that independent practice as hospitals and systems look for potential cheaper labor that they can get that may not have the specialty control. This may not be a question that has anything to do with ACGME. It may just be the idea that hospitals sometimes put profits over quality. But a lot of times, there is a reason we're a specialty, and that's because it requires specialty care. Why many states now are pushing for a physician in every emergency department because of that need. When people see a red sign, to see a physician, hopefully a board certified emergency physician. Do we believe this will impact that dynamic of the expanded scope of practice of folks not trained in emergency medicine while growing out in this 4-year plan for emergency physicians?
It's an interesting question, and I'll reflect back on my 30 years of practice. When I was a resident, we had 2 PAs in our department, and now we've got literally dozens of PAs in our department. And so, how did that happen? I don't really know. Why did it happen? I'm not really sure. There's market reasons, there's practice reasons, there's all kind of stuff that the ACGME doesn't really have a lot to do with, and has really literally no control over. What will this do to the portfolio providers in the department? I don't know. I think some of what we've written is going to change the way the residents work in the department, so the attendings will change the way they work in the department. Whether that impacts on the PAs and the NPs that provide great emergency care every day, I don't know. But what is true is that those of us, the emergency physicians that work in places with APCs, have to be able to support them and supervise them and make sure that they're providing good care too, when that's appropriate. So good training for emergency physicians is good care for our patients. And if that means that we're supervising PAs and NPs in the department, well, then so be it. I think that will get figured out. It won't be the ACGME that figures that out. It'll be all those forces over my 3 decades here that drove the number of PAs and NPs in our practice. And I've worked forever in a not-for-profit. And while we're not a for-profit hospital, we're also not for loss. So you have to make it work, right? Your health system has to make it work. We have to keep the lights on. And I think that this is part of a much larger question that has nothing to do with the ACGME requirements per se.
I think it's the same. I feel like we'll say the same thing, right? I mean, it's about the education and what's the education that's needed. And I think we were asked this question recently at Cord by someone, and we're not going to not advance our specialty and provide the training that we believe is required based on what our stakeholders have told us, because we don't want to that there's concern that someone with less training is going to be more competitive to an employer. Our goal is to have the patients cared for the way they should be cared for, and hopefully people will see the benefit of having residency trained physicians in their environments. And I think that part of the impetus for some of our curricular proposals are because there are PAs in so many of our locations, like low acuity areas, where our residents are not receiving that education and don't feel confident to work in some of those same locations where a PA might be currently more effective or more efficient because they do that all the time. So I think that while it definitely doesn't play into any of our decision making, I think our hope is that residents will be able to be more effective in all environments moving forward, including those that have our nurse practitioners and physician assistants.
Yeah, I was going to say something very similar to Linda, and I would just add that, there are proposed requirements that bolster training in leadership in the ED, as physician as the leader, leading resuscitations, leading teams in the emergency department, being more cognizant of leading communications and so forth. So we are the leaders of the clinical care teams in the emergency department.
And we're going to start now with this. If you let you off the hot seat a little bit. Hopefully, nothing too incendiary. I'm sure you've heard most of it by now. Anyway, I'll give the site here in a minute with regard to the public comments, which are due by May 1st of 2025. So a little bit of time there. So I'm going to talk from immediate past chair, well, not immediate past. Well, I guess you are immediate past chair. Just been a few years. To chair to incoming chair. Any closing thoughts and messaging? Right now, my listenership tends to be community emergency physicians, some academic, some folks, other healthcare professionals, whether it's nursing PAs and NPs. But for those community emergency physicians and young physicians out there, your closing thoughts and messaging regarding the ACGME requirements and updates that we may see on the horizon. Go ahead, Doug.
Well, you know what? I was on shift today. I worked today in the ER, and I was talking to some of our program leadership, and what they said I thought was a very healthy view of this. We're going to have to make some changes, but that's pretty cool. That could be pretty exciting. And taking the opportunity to start over and think, how could we do this, and throw some spaghetti against the wall and do some strategic planning and some brainstorming is healthy for all of us at work and at home and everywhere else. And I think that I'm excited about what this may mean to our program directors. And, I think if you're in community practice or if you're in academic practice, it really doesn't matter. You're going to hire new graduates. They're going to join your practice at some point, even if they're not brand new. And you need to be sure that the people you're signing out to are well trained. You need to be able to take cases from people that have provided good care. And I think that the community of emergency medicine can be excited about this change as we evolve our specialty even further.
All right, Linda, I'll send the same thing to you, just letting you know that Dr. Kellen volunteered you for this podcast before the webinar was even over. So it was going to happen either way. So your closing thoughts?
A couple closing thoughts. Change is really hard. It makes people uncomfortable and upset and angry, and we recognize that. And I think, in particular, knowing that the majority of your listeners may be listeners who trained at a 3-year program, or who are affiliated with a 3-year program, right? I want to just say it again. The new proposed program requirements are in no way a judgment on prior training, a comparison on one program format being better or worse than any other training format. It is really looking forward and building a new curriculum that accommodates the curricular elements that we feel are essential based on what our stakeholders told us. Our stakeholders didn't say, oh, those 3-year grads, don't have enough low acuity. They said the graduates you send us, period, end of story, including all of them, do not do these things well. And so we're hoping to reframe and restructure, not just by saying, we're going to extend training, but every program is going to have to make a change, even the programs that are currently in a 48-month format. I'll end by saying, please give us feedback. I know you're going to give the open comment link and everything, but please also listen to the webinar and read the article and try to understand why we are making these changes or proposing these changes, so that we can have a dialogue that is, we're on the same level, right? If we're just thinking about, well, how are we going to do that? Or, what is that going to look like implementation wise? And we're talking about why we're doing it. We're not having a conversation about the same thing. And so for us, the why is the most important thing. I think we've had a lot of talk about the why during this past 50 minutes or so. And that, give us information, give us suggested changes about what we put out there for proposed program requirements that meet the why. And, we're happy and excited to see what people propose in in contrast to what we've proposed. Nothing is set in stone. Everything is in proposed format right now. But we know change is really hard. But please read the information so that you can give us effective information to work forward with as we go through the next steps of the process.
And I'm glad you mentioned that part because, as mentioned earlier, with the survey to Cord, but also the number of stakeholders that have been involved with some of this feedback and information that you've had. These were not decisions that were made inside a vacuum, and now clearly, with the receiving of open feedback for the next couple of months, there's interest in how it's received and other ideas as well. So, Tiffany, as the person who gets to inherit this, your closing thoughts as well.
Yeah, thank you. Just to tag on to what Linda said, there is a lot of information out there in addition to the program requirements and the impact statement, the procedures, the webinar, the article that we put out explaining our process on how we came up with the 48-month with the survey and the supplemental information is out there. So we're not trying to hide anything. If people have questions about the survey, we welcome them to go and look at the survey. I know that there were some questions about the survey as well. I do want people to realize that these are proposed. So nothing is set in stone right now. And as Linda said, we really want everyone's constructive feedback. We realize that there may be things that, we need to tweak. Maybe there are different perspectives that we didn't think of, and we want to hear about that. So we do want to encourage that feedback in the review and comment section. And I think that it's important for people to realize, and the one theme that I think that I've been hearing time and time again is really the comparison of the 3 versus 4 years. The program, I trained at the 3-year program and I did fine. And I know plenty of physicians who have trained in 3-year programs and they're doing great. We're not comparing program A, which is 3 years, to program B, which is 4 years. We created program C, which is a forward-facing program that will train the emergency medicine residents and physicians of the future. So, it was a process that took a very long time. It was a process that, I mean, many stakeholders, many conversations, a lot of input, all of which we considered. And we, as you said, we didn't create these requirements in a vacuum. So we really appreciate this forum and this opportunity to, spread the word and make our voices heard.
Well, I really appreciate it, Dr. Linda Reagan, Dr. Doug McGee, and Dr. Tiffany Murano. And as mentioned, I loved how you mentioned the constructive feedback. Everybody can keep their hate mail to themselves. If you're going to give feedback, let's make sure it's productive feedback. And remember, there are humans and emergency physicians on the other end of this as well. They're trying to promote and grow and further solidify this specialty. ACEP has gone together and put together all the things at this point that you're looking for this. On the page, you can actually just look up the ACGME releases proposed changes to EM program requirements. You can shorten that if you want, if you just add ACEP. And it's under the News and ACEP Newsroom tab. This actually has highlighted as hyperlinks the new proposed emergency program requirements. It also has the rationale, which is what a lot of you are looking for, which is why these decisions were made. You can actually watch the ACGME webinar from that page as well. And there's a direct link highlighted in gray with with blue print. Click here to submit your comments directly to this ACGME. And under that is a bullet pointed summary of exactly what we are talking about here. So all of that there is at your fingertips. You can also go to the ACGME for details or FAQs, and you can directly link the comment section as well. But the ACEP one was easy for me to find, and I think it summarizes it very well and was good to follow along here. And with that, look forward to it. I appreciate your time and willingness to not only take some of the easy kind of softball explanations, but feedback on, some of those things that are flaring up online as well, because those are a lot of the questions and emotions that are out there. And a lot of it does happen to be with more of the questions than answers for many people. And hopefully when digging into it can understand and then provide that constructive feedback. Remember, you need to do it by May 1st. So if you're listening to this on May 2nd, you can ignore the last few minutes on the feedback because you missed your chance. But otherwise, appreciate you guys joining me, the rest of the team that's in the background as well. And as for me, you can contact me at rstanton@acep.org, rstanton@acep.org, or at everydaymed on X. Make sure that you're subscribed to the podcast so you can get all of this information and education, and also answer those questions, hopefully, that you have out there. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.